Let's move further into this topic of blood pressure. We have discussed determinants of arterial blood pressure and the types of blood pressure, measurement of the blood pressure, and now the most important part actually, the regulation of blood pressure. In fact, if you see the questions which asked in the entrance exams, majority of the questions have appeared from this section. Let's therefore understand this topic in detail and what all questions have been asked or are likely to be asked. I will give you some sample questions first and then we discuss the answers as we go along. Okay, first question. There are two students, A and B. They are performing an experiment on the dogs, two different experiments. A is going to cut the carotid baroreceptor nerve, that is 9th cranial nerve, when the blood pressure was 80 mm of Hg in that first animal. Then the second student, B, in another dog, in another experimental animal, he cuts the 10th cranial nerve, means aortic baroreceptor nerve in that second animal, when the blood pressure was 80 in that second animal. So, what will be the result that they get after sectioning of those respective nerves in two different animals? That was the question. So, you have to know the basics of baroreceptors and their impulses. Then you will be able to solve this question. It appears to be a very problem-solving type of an MCQ or clinical type. But you have to know the basics. So, I stand by my statement which I made at the beginning of this year's video recording that the questions can come in any format. Your basics should be strong and you will be able to answer those questions correctly. So even here, two dogs, experimental animals, one cuts the 9th nerve when the blood pressure was 80 in that animal, second cuts the 10th cranial nerve when the blood pressure was 80 in that second animal. And what will be the result that they obtain after sectioning of the nerve? And the options are both will get increased blood pressure after cutting the nerves, or both will get decreased blood pressure after the sectioning of the nerve, or increased BP in the first one but no change in the second animal, or no change in the first animal but increased BP in the second animal. So these were the options given. You want to answer that just now or you will wait for the discussion to happen? Well, in first animal the BP will rise and in the second animal there would not be any change. Why is that? We will understand once we discuss this. Okay, and there are many more questions. For example, at what blood pressure? At what existing blood pressure the impulse discharge frequency from the baroreceptors will be maximum? And the options given are 60, 100, 150, 180. These blood pressures are mean. Take them as mean blood pressures, mean arterial pressure. So what's your answer? I know many of you start thinking that it must be 60 because the BP is falling, so baroreceptors will discharge maximally. No, I'm afraid that's not the answer. The answer is actually 180. Why? We will see that. Take one more and then we will start the discussion. Related to the baroreceptors. Baroreceptor system is most sensitive and most efficient at what blood pressure? And take same four options: 60, 100, 150, 180 mm of Hg. Now you must be thinking 60. This time it must be 60 because BP is falling, cerebral blood flow will decrease and therefore baroreceptors have to be very, very sensitive to that. No. Again the answer is not 60. This time the answer is 100. Why? We will see that in the due course of our discussion. Let's begin. Blood pressure, just like any other homeostatic regulation in the body, even the blood pressure will be regulated chemically and neurally. Let's see the chemical regulation of blood pressure first. The chemicals that cause vasoconstriction or vasodilation, and I have already mentioned this, that vasoconstriction will increase the peripheral resistance and therefore increase the blood pressure. Vasodilation means fall of blood pressure. So vasoconstrictors that will increase the blood pressure. The most important ones, vasopressin, yes, ADH or vasopressin, it has this action of vasoconstriction. You know, vasopressin has two types of receptors, V1 and V2. So V1 receptor would mediate this action. V2 receptors, of course, in the renal tubules for the water reabsorption via aquaporin 2 channels. Okay, then norepinephrine, the catecholamines or norepinephrine sympathetic discharge. Then, very important one, angiotensin. Okay, by the way, that reminds me of an MCQ which was asked long back, and it appears to be a trick question because more than 80% students give wrong answer to this particular MCQ. Well, the question is, angiotensinogen is synthesized by which organ? Angiotensinogen is synthesized by which organ? And the options given are liver, kidney, lungs, or heart or brain. Take one more option. Most of the students first think of lungs because they get confused between ACE, the angiotensin converting enzyme, and this particular angiotensinogen. Okay, the question is on angiotensinogen. Then some students even think kidney, thinking that it is renin which is being asked. So renin by the kidney. No. Angiotensinogen, I will write it here because it's not a part of our main discussion. It's just an additional point. Angiotensinogen is a plasma protein, and just like any other plasma protein, this will be synthesized by the liver. It will come into the plasma, into the blood, and then renin, which is synthesized by the kidney, the JG cells in the kidney, this renin will act on this angiotensinogen to convert it into angiotensin 1, which is a decapeptide. And then while it is passing through the lungs, the lung capillary endothelial cells, they will have that enzyme ACE that will form angiotensin 2, which is an octapeptide. So you see why people got confused, because three organs are involved in this renin, angiotensin, and finally aldosterone, of course. There is a liver which synthesizes angiotensinogen, there is kidney which synthesizes renin, and lungs which are synthesizing the ACE, which are causing the conversion. So that was the question. Well, coming back to our main discussion, angiotensin is a very potent vasoconstrictor. You know, in fact, I can tell you right now, presently, the drugs that lower the blood pressure, the antihypertensives, are mostly targeted at angiotensin. I mean, preventing the formation of angiotensin 2, because it's a very potent vasoconstrictor. It has long-term effects. Then, of course, we have most potent local vasoconstrictor substance, endothelin. Most potent local vasoconstrictor substance. Yes. Now, endothelin has its receptors ET, ET1, ET2, and they have the subtypes also, A, B, and so on. So all these receptors will mediate vasoconstriction except ET2B. Now this receptor mediates vasodilation, and that is said to be an inherent check on the excessive vasoconstricting ability of endothelin. However, apart from that, you can just keep in mind the most potent local vasoconstrictor is the endothelin, and most potent circulating vasoconstrictor substance discovered so far is urotensin. Now hardly anything is known about this so far, but many authors are saying that this is the most potent circulating or systemic vasoconstrictor substance discovered. Okay, so please keep this in mind. Local versus systemic. All right. Let us see the vasodilator substances. Vasodilators that will decrease the blood pressure. Vasodilator chemical or the mechanisms. Okay. Hypoxia, an important vasodilator. Then we have CO2, H plus, lactic acid. These are also vasodilators. Histamine, another vasodilator which is released in the allergic reactions. Then the most potent vasodilator substance, of course, is NO, nitric oxide, which is also called as endothelium derived relaxing factor, EDRF. Most potent. So those drugs which will upregulate the enzyme NOS, nitric oxide synthase, they will also have the effect of vasodilation, a strong vasodilation. Right. Let me just add a few things in this. Hypoxia causes vasodilation everywhere except in the lungs. Let's write it here. Except in the case of lungs, in the pulmonary circulation. In the lungs, it causes vasoconstriction. I have described it in detail elsewhere, so let's not spend time on that. Just remember that in the case of lungs, the vascular smooth muscle cells have O2 sensitive potassium channels and they mediate vasoconstriction. Whereas in the systemic circulation, hypoxia causes vasodilation because the vascular smooth muscle cells in the systemic circulation have ATP sensitive potassium channels. We have seen that in detail in the first chapter itself. One more point, the CO2. Let me say something about CO2. Look, CO2 is a local vasodilator. That's right. But it's a systemic vasoconstrictor. What do you mean this by this? If CO2 accumulates in the tissues, it will cause a local vasodilation. But if CO2 accumulates in the medulla, where there is vasomotor center, then it is known to stimulate the vasoconstrictor area, and that will cause intense vasoconstriction throughout the body. And in that sense, CO2 is a systemic vasoconstrictor. Okay, we will discuss this once again in the context of CNS ischemic response. But so far, these are the chemicals or the mechanisms that chemically induce vasoconstriction and vasodilation and cause changes in blood pressure. Now, the neural regulation of blood pressure, and I will associate this with the short-term regulation as well, so the correlation can be better. Therefore, let's begin with the first mechanism, which is the baroreceptor mechanism or baroreflex mechanism. We have seen 3 MCQs at the start of this section, and all 3 were related to this mechanism. So it's a very important mechanism to understand. Okay, let's begin. First point, baroreceptors are stretch sensitive mechanoreceptors. So baro is a misnomer. They are not actually responding to the pressure changes in the blood vessel. They are responding to the stretch of the vessel wall, which is caused by changes in blood pressure. That's the first point. And they are mechanoreceptors. They have a mechanical stimulus which will open the channels in their membranes. Right. They are spray type nerve endings. Spray type nerve endings, which will then give rise to the cranial nerves 9th and 10th. You know, in the muscle spindle also we find spray type nerve endings, the flower spray endings. So somewhat similar. They are at two locations. Let's have a diagram so that we have a better visualization. Carotid baroreceptors and aortic baroreceptors. Well, since we are talking about the blood pressure regulation in general, we are sticking to these carotid and aortic baroreceptors. But generally speaking, there are baroreceptors which are of two types: low pressure baroreceptors and high pressure baroreceptors. These are high pressure baroreceptors, means they are located in the situations of high blood pressures. So remember three such locations: carotid artery, arch of aorta and renal artery. At these places there are high pressure baroreceptors. The other variety is low pressure baroreceptors, which are there in the right side of the heart, right ventricle, pulmonary artery. These are low pressure situations. Right. Coming back to these, the baroreceptors that regulate the blood pressure. So the common carotid artery divides into internal and external carotid artery, as you can see here. Just above the bifurcation, the wall of the carotid artery, internal carotid artery, is dilated. So this dilation is called as carotid sinus. And in the wall of the carotid sinus, there are these carotid baroreceptors. That's the first point. Wall of the carotid sinus. And below the bifurcation into the common carotid, there would be, somewhere here, there would be carotid chemoreceptors, the chemosensitive cells. Okay. So, and they are called as carotid bodies. Remember, therefore, if we call it carotid sinus, we are talking about the baroreceptors. If we say carotid bodies, we are talking about the chemoreceptors, chemosensitive cells. We will talk about them in some time. Okay. And in the wall of the arch of aorta, there are aortic baroreceptors. Aortic baroreceptors. From the carotid baroreceptors, a short nerve arises, which is called as Herring's nerve. Herring's nerve, which then joins the glossopharyngeal nerve, ninth cranial nerve. And from the aortic baroreceptors, 10th cranial nerve arises, and 9th and 10th cranial nerves, therefore they are the afferent nerves arising from the baroreceptors and going to the medulla, vasomotor center in the medulla. So I'll just write it here. They are sending signals to the vasomotor center. So that's one aspect about the baroreceptors. Okay. We will talk about the vasomotor center also, but let me say a few more things about baroreceptors. Baroreceptors operate in the range of 60 to 180 mm of Hg, and this is the mean blood pressure. Mean arterial blood pressure of 60 to 180, that's the range for the baroreceptors. To be more precise, this is the range for carotid baroreceptors, and aortic baroreceptors operate in a range which is 30 millimeters higher as compared to the carotid baroreceptors. So the range will be 30 millimeters higher, means 90 to 210 mm of Hg. The reason is aorta is a thick walled vessel compared to carotid artery, internal carotid artery, and therefore the aortic baroreceptors need a higher level of pressure to get stimulated. So this itself will tell you the answer to the first MCQ which I mentioned. Two students were performing an experiment on two different animals. First student cuts the ninth cranial nerve when the blood pressure was 80 mm of Hg, and second student cuts the 10th cranial nerve in the second animal. He is doing it in the second animal. He will cut only the 10th cranial nerve when the blood pressure was 80 mm of Hg in that second animal. So, what will be the result? You will get the response only in the first animal, but wouldn't see the response in the second animal because aortic baroreceptors are operating in a range of 90 to 210, and therefore at 80 mm of Hg they were not even functioning. Therefore, there would not be any change in the impulse pattern going from the baroreceptors, and therefore there will not be any change in the blood pressure in the case of second animal. We will talk more about that MCQ later once we are done with this entire discussion. Okay, what else? Yes, nerves. 9th and 10th cranial nerves are called as buffer nerves. They buffer the changes in blood pressure, therefore they are called as buffer nerves. That was a summary of baroreceptors. Coming to the vasomotor center, where the impulses are being sent. Let's talk about the vasomotor center in the medulla. Okay, here is the medulla. There are 3 to 4 groups of nerve cells collectively called as the vasomotor center. Why did I say 3 to 4 groups? Either it will be 3 or 4. Why did I say 3 or 4 groups? That's because 3 groups of cells have been well established. Their function is clearly established, and the 4th one is not clearly established. That's why I said 3 or 4 groups of nerve cells. What are those groups of nerve cells collectively called as the vasomotor center? Are these. First one is nucleus of tractus solitarius. Nucleus of tractus solitarius is the sensory nucleus. You know, nucleus in the CNS is collection of nerve cell bodies. So this is the sensory nucleus for 9th and 10th cranial nerves. That means whatever impulses are coming from the baroreceptors regarding the blood pressure, existing blood pressure or changed blood pressure, those impulses will be received by the nucleus of tractus solitarius. Then we have one area that will increase the blood pressure, that can increase the blood pressure, and the other area, which is a cardio inhibitory area, it will decrease the blood pressure. Let's see those areas. Okay, there is an area which is called as RVLM, rostral ventrolateral medulla, RVLM. Well, this is the vasoconstrictor area. Vasoconstrictor area. What is the meaning of this? There are nerve cell bodies located in this area, and the axons are sent down on the spinal cord. These axons that are coming from this area, they will end on the intermediolateral horn in the spinal cord. And what is located in the intermediolateral horn of the spinal cord? The sympathetic nerve cell bodies, which means the sympathetic nerve cell bodies will arise from here and there will be a sympathetic discharge. So sympathetic discharge is controlled by this RVLM. Whenever this area is firing, there will be an increased sympathetic discharge, particularly from T1 to L2 segments of the spinal cord. These axons will go on ending at each level between T1 and L2, and it causes vasoconstriction. Well, let me add here, there is something called as vasomotor tone. Under basal conditions, vasomotor center is firing tonically, a low level continuous firing, tonically active, and that is actually a vasoconstrictor tone, meaning that the vasoconstrictor area is tonically active, this RVLM. And because it is tonically active, therefore, the blood vessels are in a 50% constricted state already. So please remember, the blood vessels under normal metabolic rate, normal resting conditions, the blood vessels are in a partially constricted state, and that's because of the vasomotor tone or vasoconstrictor tone. And partially means about 50% of the maximum constriction. Another area which is called as cardio inhibitory area. Cardio inhibitory area. Where is it located? Well, it is, I'll just write it here, dorsal motor nucleus of vagus. Dorsal motor nucleus of vagus. So that's the cardio inhibitory area. You know, vagus, parasympathetic discharge. So, these are the vagal efferent fibers which arise from this. Look, there were vagal afferents which were coming from the aortic arch and going to the vasomotor center, and vagal efferents will come out and they will control the heart rate and cardiac contraction. So that's the cardio inhibitory area. There is also a cardio accelerator area, as I mentioned, the fourth area, not clearly established, but these three are clearly known. Now what happens is, suppose the blood pressure falls, impulses will come from baroreceptors to the nucleus of tractus solitarius, and now the BP needs to be increased. It has fallen, that means it has to be brought back to normal. The baroreceptors have a set point. So what happens is, the nucleus of tractus solitarius then will excite the RVLM, and that means vasoconstriction will happen and the BP will increase. Whereas if the blood pressure has already increased and it needs to be brought back to normal, then RVLM, that vasoconstrictor area, will be inhibited. So there will be vasodilation and cardio inhibitory area will be excited. So vasodilation and heart is inhibited, the blood pressure will fall as a result of that. Okay, that is how this whole system works, and that's how the baroreceptor mechanism is all about. Now the most important point is coming up about the baroreceptor function. Well, the baroreceptors have a set point, a natural set point, and it is normally set at about 100 mm of Hg of mean arterial pressure. So that's a set point. And you know, if the blood pressure increases, it is brought back to 100. Blood pressure decreases, it is brought back to 100. That's a set point. In fact, you know, if we have such an efficient mechanism to regulate the blood pressure, then why do people suffer from hypertension? The reason is resetting of baroreceptors. You know, if a person is consistently exposed to a higher blood pressure, then within 1 to 2 days, there is a resetting of the baroreceptor set point. The baroreceptor set point will be reset to a higher value, and then they would be functioning for that particular blood pressure. And therefore, you know, it is only effective for a very short term regulation. When I say short term, it means quickly acting, and the effect lasts for a few minutes or so. That's a short term. Whereas long-term mechanisms will be, they will start acting slowly and the effect will last much longer. Therefore, that is the baroreceptor summary of baroreceptors, but the most important point is yet to come. Yeah, I just mentioned it. The most important point is coming up now, and that is, we have already said that the range is 60 to 180 mm of Hg for the carotid baroreceptors. And now, how is this whole system functioning? It is functioning on the basis of frequency modulated signaling. And by frequency modulated, I mean action potential frequency. Action potentials arising from the baroreceptors. Okay, these are stretch sensitive mechanoreceptors. So when the blood pressure will change, the baroreceptors will be distorted, and in their membranes there are cation channels which will open, and they will give rise to a receptor potential which will cause impulses in 9th and 10th cranial nerves. So frequency of action potentials, that is the basis for this particular functioning. Now look, at 100 mm of Hg, there is a steady impulse discharge from the baroreceptors. 100 mm of Hg is the normal blood pressure, normal mean blood pressure. There will be a steady impulse traffic going from the baroreceptors to the vasomotor center. When the BP increases, the impulse discharge frequency will also increase. And when the BP decreases, impulse discharge frequency will also decrease. The most critical statement that I have made so far, most important statement that you need to understand is this. Because see, how will the nucleus of Tractus solitarius know that the BP has increased or decreased? And how much BP has increased or decreased? It entirely depends on this frequency modulated signaling. That at 100 mm of Hg, there is already steady impulse discharge. And let me add, when the heart ventricle goes in systole and blood is ejected out into the aorta and carotid artery, that distension of those vessels will cause an oscillatory impulse discharge. So please remember, baroreceptors show such oscillatory impulse discharges, right? And therefore, now you can answer that question. I asked you one question that at what blood pressure the baroreceptor impulse discharge frequency will be maximum. See, it will be lowest at 60 mm of Hg, the impulse frequency will be least at 60 and highest at 180. Very clear from this. Decrease blood pressure, decrease impulse frequency. Increase blood pressure, increase frequency. So naturally, highest will be at 180 and least will be at 60. So that is how this entire system works. And to understand all this, I will simply draw a graph. Remember this graph and you will remember everything. The graph is about blood pressure and it is plotted against impulse traffic or impulse discharge frequency. Right. And let's take the blood pressures 60, 100, 150, 180. And the graph is S-shaped. There are many S-shaped graphs in various body systems. This is one of them. What is the meaning of S-shape? Let's understand. Here is the S-shaped graph. So we are seeing 2 points in this. One is lowest impulse discharge frequency is at 60 mm of Hg. Highest impulse discharge frequency is at 180 mm of Hg. See, 180 mm of Hg, maximum discharge. But let's see the answer to that last MCQ which we had discussed. The baroreceptor system is most sensitive at what blood pressure? If you are thinking 180 because maximum impulse traffic is going at 180, that's not the answer. The answer is, okay, let me tell you, before I tell you the answer, let me just add one line. Any homeostatic regulatory mechanism, baroreceptor system is a homeostatic regulatory mechanism. Although not a very efficient mechanism, it has got a gain of only about 2 to 4, which is very low gain. But still, any homeostatic regulatory mechanism operates best near its natural set point. Isn't that very obvious? That at it near its normal set point, natural set point, it will operate best, because it has to bring the control variable back to that natural set point. In this case, it is blood pressure. So you can watch the graph. Around 100 mm of Hg, the graph is steep portion in the middle, around 100. See, let us see that with a broken line. See the graph around 100. The curve is steep, which means what? Which means for any change around 100, this side or that side, the impulse discharge frequency will change greatly. Okay, that means what? That means the system is very sensitive around this blood pressure, obviously. So that's a very important point. And please remember for all such questions that any homeostatic regulatory mechanism will operate most optimally around its natural set point. For baroreceptors, it is 100 mm of Hg. Alright, so that was baroreceptor mechanism. Now coming to the next, it's only up to 60 mm of Hg that the baroreceptor system works. What will happen below 60 mm of Hg? Will the blood pressure not be operated? Yes, it will be regulated. It will be regulated by the next mechanisms. I'll come to those mechanisms in 2 minutes. Just I wanted to just go back to that first MCQ which I asked. There were two students which were performing an experiment. First student cuts the 9th cranial nerve when the blood pressure was 80 in one animal, and second student cuts the 10th cranial nerve when the blood pressure was 80 mm of Hg in the second animal. What is the result? What will happen when you cut the 10th cranial nerve when the blood pressure is 80 mm of Hg? The impulse traffic to the vasomotor center will not be altered, because at 80 mm of Hg there were anyways no impulses going in the 10th cranial nerve, isn't it? We've already seen this, that in the case of aortic baroreceptors, they operate at 90 mm of Hg, above 90 mm of Hg, and therefore at 80 there were anyways no impulses. So cutting off that nerve will not change any impulse pattern going from the baroreceptors to the vasomotor center. So no change in the second animal. Now coming to the first animal, if you cut the 9th cranial nerve at when the blood pressure was 80, yes, there were already impulses in the 9th nerve, and the cutting of the nerve will mean what? The impulse traffic to the vasomotor center will decrease, and now we know already that decrease impulse traffic is taken as a decrease in blood pressure, isn't it? We saw that some time back, that impulse discharge frequency decreases means it is taken as a fall of blood pressure by the vasomotor center, and it will react, and it will increase the blood pressure. It will cause the vasoconstriction and increase of blood pressure. So the animal was at 80 mm of Hg and the 9th nerve was cut, the blood pressure will increase. It will hover around normal range, but it will definitely increase because of this particular pattern of discharge. Right, so that was baroreceptor mechanism. Below 60, who will operate and regulate the blood pressure? It's the chemoreceptor mechanism. Chemoreceptor mechanism generally operates in a range of 60 to 30. There is a variation in different authors. Some say 60 to 40, some say 60 to 25. This looks to be the average figure. From 60, if the BP is falling further up to 30 mm of Hg, there would be a chemoreceptor mechanism. How will it work? In the common carotid artery, there is one carotid body on each side. Carotid body in the common carotid artery, one on each side. That means we have two carotid bodies, one on each side in each carotid. So here is a common carotid. It has a carotid body which has glomus cell. There are two types of glomerulus cells, type 1 and type 2. And in the arch of aorta, there are several aortic bodies. In the wall of the arch of aorta, several aortic bodies. So first thing, we have two carotid bodies and several aortic bodies. What is so special about carotid bodies or these chemoreceptors? These are locations for peripheral chemoreceptors. They have chemosensitive cells. They are going to sense the chemicals. Second point is they have massive blood flow. They have massive blood flow. So, they are always bathed in arterial blood. Massive amount of oxygen is being delivered to them. And therefore, as I mentioned, they are bathed always in the arterial blood. The other thing is, the glomus cell, let's say this is one glomus cell in that carotid body. In its membrane, it has the channel which is O2 sensitive potassium channel. Oxygen sensitive potassium channel. So, first thing that you should understand is that these chemoreceptors, chemosensitive cells, they are going to sense the chemical. Which one? The oxygen. They are going to sense hypoxia. So when there is hypoxia, it will be sensed by this O2 sensitive potassium channel and it will close. O2 sensitive potassium channel will close after sensing the hypoxia. And as it closes, the potassium that was supposed to go out, it will not go out and it will accumulate inside the cell, inside the membrane. And this glomus cell will depolarize. And then the impulses will be sent via 9th and 10th nerve. The impulses will be sent to the vasomotor center and as well as to the respiratory center, because it is being sensed as a hypoxia. Now the only thing that I want to join the dots is, we are talking of blood pressure. So where hypoxia is fitting into this picture? Okay, when there is decreased blood flow, when there is decreased blood pressure and it falls below 60 mm of Hg, that's very low in itself, there will be a decreased blood flow to the carotid and aortic bodies, peripheral chemoreceptors. And decreased blood flow to chemoreceptors is sensed by them, it is sensed by them as hypoxia. Okay, so it's a hypoxic stimulus for the glomus cell which is present inside the carotid body. But why it has caused? It has caused because of a fall in blood pressure. That is where we join the dots. And so the signals will arise, they will go to the respiratory and the vasomotor center, and then the blood pressure will be increased, brought back to normal, respiration will be stimulated. That was the chemoreceptor response. If the BP goes below 30 mm of Hg, then who will regulate the blood pressure? It's called as CNS ischemic response. CNS ischemic response. It is also called as last ditch stand. It means a last ditch desperate effort to increase the blood pressure. So, blood pressure falling below 30 mm of Hg up to even 0 mm of Hg, we will see a CNS ischemic response which is called as a last ditch desperate effort. Okay, how does it work? If there is a decreased blood pressure and it has come in this range, 20 mm of Hg, then there is decreased blood flow to the medulla and to the vasomotor center. That's why it's called CNS ischemic response. Reduced blood flow into the CNS, into the medulla. Reduced blood flow to the vasomotor center does what? See, if there is a vasomotor center and blood flow is reduced, so what will happen? CO2 cannot be washed away from this region. Blood flow has decreased. So, CO2 accumulates near the vasomotor center. And we have already seen this, that the CO2 then will cause an intense vasoconstriction throughout the body. RVLM, vasoconstrictor area, will be strongly stimulated. There will be intense vasoconstriction throughout the body. So much so that blood pressure, which was hovering around 20 mm of Hg, will now go to 200 mm of Hg. Yes, that's possible. That does happen in fact. In fact, in your clinical life, you might come across such cases once in a while, where there is a roadside accident, some bleeding has occurred, you will expect the blood pressure to have decreased, but when you actually check it, you find it 180 or 200 mm of Hg. Yes, that's possible, and that's because CNS ischemic response was triggered. So that is one more short-term regulation of blood pressure. Well, there is one variant of this which is called as Cushing reaction. Cushing reaction is another form of CNS ischemic response. It's a substitute or another form of CNS ischemic response. But in CNS ischemic response, the blood pressure had fallen and therefore there was CNS ischemia. Whereas in the Cushing reaction, there is increased intracranial tension, increased CSF pressure or increased intracranial tension. And because of this increased ICT, the intracranial tension or the CSF pressure becomes more than the cerebral artery pressure. So you can imagine CSF is surrounding the brain and the medulla, and here is the cerebral artery which is inside. So if the surrounding pressure becomes more than the artery pressure, what will happen? The artery will be occluded, the blood flow will stop. So ischemia, blood flow stops means ischemia, basically blood flow decreased, and CNS ischemia will be triggered. So that's called as Cushing reaction, an alternate form of CNS ischemic response. Only thing is, the one which we said just now, last ditch stand, it was because of a falling blood pressure, and this Cushing reaction is because of an increased intracranial tension rather than a fall in blood pressure. These were the short-term mechanisms for the regulation of blood pressure. Now coming to the intermediate term and long-term mechanisms. Intermediate term means they take some time to start operating and their effect will also last for some longer duration. So what are these intermediate term mechanisms for regulation of blood pressure? For instance, ADH and thirst mechanism. This will come into effect when there is a decrease in blood pressure. Well, keep this in mind that ADH is primarily not responsible for regulating the blood volume and blood pressure. ADH is primarily responsible for regulation of osmolality of the plasma, osmolality of the body fluids. But then, for example, circulatory shock, second stage, now it's becoming a worse condition, right? So any and every mechanism will have to be put into effect to save the person, and therefore ADH will come into action. And ADH will retain water from the kidneys, so water comes into the blood volume will increase and blood pressure can increase. Of course, it will change the osmolality status of the body fluids for some time, but body has to tolerate that changed osmolality because it was a question of life and death. Blood pressure was falling, blood volume was less, cerebral blood flow was decreasing. So ADH and thirst mechanism. Thirst, the person will feel thirsty, and the fluid intake and the fluids will be absorbed from the GIT, blood volume and blood pressure will increase. We have capillary fluid shift mechanism. What is capillary fluid shift mechanism? When there is increased blood pressure, the tissue perfusion pressure also increases. The capillary hydrostatic pressure also increases in the tissues. And hydrostatic pressure, capillary hydrostatic pressure is a force that pushes the fluid out of the capillaries. Which means what? Which means there will be a decrease in the circulating blood volume. And also there will be a decrease in blood pressure. So this is what happens when the blood pressure increases. Another mechanism comes into effect when BP has increased, and that is atrial natriuretic factor or atrial natriuretic peptide. Increased blood pressure and increased blood volume and blood pressure leads to what? Leads to increased venous return to right side of the heart. So there is increased atrial filling pressures, increase in the atrial filling pressure. This causes atrium to be stretched, and that stretch of the atrium will cause release of atrial natriuretic factor. Atrial natriuretic factor, it then will cause, it will go to the kidneys. Released from the atria, it will go to the kidneys. It will result in natriuresis and diuresis. So, sodium and water will be lost into the urine. Blood volume and blood pressure will return to normal. These are the intermediate term mechanisms. Finally, let's come to the long-term mechanisms. Long-term mechanisms, you have to know at least two mechanisms. One is RAAS. We have discussed it at various places in the videos. And kidney body fluids mechanism. Kidney body fluids mechanism in the regulation of blood pressure. So, long-term means they take some time to be activated. Longer time. Okay, we saw baroreceptors half to 1 second will be activated, but the effect will stay for short duration. These will take longer time to be activated and their effect also will stay for longer duration. So RAAS, renin angiotensin aldosterone mechanism. Look, when there is decreased blood volume and there is decreased blood pressure, it will be sensed by the renal baroreceptors. We saw just now, some time back, that there are certain baroreceptors and volume receptors located in the renal artery also. So they will sense this and they will signal to the JG cell in the kidney. There will be release of renin. Look, it is RENIN. There is another renin which is RENNIN. This is also an enzyme. It's going to act enzymatically. That also is an enzyme, but it's the enzyme for curdling of milk. We will see that in the digestive tract. Okay, so this renin will come into the blood, in the plasma, and it will act on the angiotensinogen, which is coming from the liver, and it will form angiotensin 1. When this is passing through the lungs capillaries will secrete ACE, angiotensin converting enzyme. So this octapeptide angiotensin 2 will be formed. Very potent vasoconstrictor. And as I mentioned, most of the popular antihypertensives today, they are targeted at this, blocking the ACE, stopping the conversion of formation of angiotensin 2. Angiotensin 2 will have 2-3 effects. One is, by itself it causes sodium and water retention from the renal tubules. So blood volume and blood pressure will increase. The second effect is vasoconstriction. The name itself suggests angiotensin. Angio is blood vessel, tensin is tension, so vasoconstriction. And the third effect is that it goes this angiotensin 2 will go to the adrenal cortex gland, the zona glomerulosa of the adrenal cortex gland. There it will cause release of the mineralocorticoid aldosterone. Aldosterone, once it comes into the picture, it goes to the kidney, and from the kidney it causes sodium and water retention. So the net effect is, by increasing the salt and water retention or by causing vasoconstriction, there is increase in the blood pressure. Of course, blood volume has also increased because of the salt and water retention, sodium and water retention. So that's the renin angiotensin aldosterone mechanism. And the second one is kidney body fluids mechanism. Kidneys operate on a long-term basis. They adjust the urine output and thereby they regulate the blood volume and blood pressure. That's called as kidney body fluids mechanism. So how do they operate? Look, blood pressure and urine output. At 60 mm of Hg of blood pressure, that's very low, urine output will be virtually zero because blood pressure has decreased, so blood volume will have to be normalized, and therefore urine output will be virtually zero. At 100 mm of Hg, which is our normal mean blood pressure, urine output will be normal, 1 to 1.5 liters per day. And at 150 to 160 mm of Hg, 160 mm of Hg, at that high blood pressure, the urine output will be 5 to 6 times the normal. I mean, if normally the urine output is 1 liter per day, at the blood pressure 160 mm of Hg, the urine output will be 5 liters per day or 6 liters per day. And that is how kidneys will adjust the urine output, and thereby it will regulate the blood volume and blood pressure. So these were the blood pressure regulating mechanisms, short term, intermediate term and long term. If I were to add finally to the remaining part, the applied aspect, I'll quickly go through it. Of course, I know this is taught in medicine extensively, so please read it in medicine. I will just quickly summarize it for you. Changes in blood pressure are of two types. Low BP is hypotension and increased blood pressure is hypertension. This is all very well discussed in the medicine, and I hope you will read that from medicine. So hypertension by the AHA criteria, American Heart Association, if the diastolic BP more than 90 is called as the hypertension. Of course, it is if recorded on 3 different occasions and by different postures and 3 different occasions of the day, then you label it as hypertension. 85 to 89 diastolic blood pressure is considered high normal, and more than 90 diastolic BP, and systolic BP at the same time more than 140 mm of Hg. Remember, generally the systolic BP is taken to be 100 plus age in years. So 40-year-old person, the systolic BP is expected to be 140 mm of Hg. But anyways, if it exceeds 140, it's taken to be high blood pressure. And then 90 to 104 is taken as mild hypertension. 105 to 115, I'm talking about diastolic blood pressure. 105 to 115 is moderate hypertension. More than 105 to 114 is moderate, and more than 115 mm of Hg is taken as severe hypertension. And a consistently high blood pressure, diastolic blood pressure more than 130 consistently with the end organ damage is called as malignant hypertension. That's the applied aspect, but that's out of scope for this discussion. We will stick to the physiology of blood pressure and regulation of blood pressure. So that was the topic on blood pressure. Okay, let's take a smallish topic in the CVS, that's cardiovascular changes during exercise, the skeletal muscle exercise. A few questions have come in the past regarding this. For instance, a 30-year-old athlete is performing strength training. Which of the following indicators will not increase during the exercise? And remember, strength training or power lifting exercises. And the options given are heart rate, cardiac output, mean arterial pressure, or peripheral resistance or systemic vascular resistance. And very often the students tend to think that cardiac output and heart rate, they will go hand in hand in one direction. If the heart rate increases, cardiac output increases, and therefore one of them may not be the answer. So then they start thinking about the other two. Actually, the answer is this: cardiac output will not increase. That means heart rate will increase, but yet cardiac output will not increase. Why is that? We will see just now. First of all, the muscular exercises are of two types. And the cardiovascular changes that happen will be different in these two types. One is the isotonic exercise. The other one is isometric exercise. Now you will have to recall our discussion in the skeletal muscle. We've seen that there are two types of contractions, isometric contraction and isotonic contraction. So this is just a quick recap of that. When a skeletal muscle contracts, two things are happening. If you remember, we've done this already. Two things are happening. Tension is generated in the muscle and the muscle shortening happens. These are the two things that happen when the muscle contracts. When we say isometric exercise, you remember we have said this. During isometric contraction, only tension develops, but there is no muscle shortening. That is isometric contraction. And isotonic contraction means after a certain tension is developed, then that tension will remain the same and the muscle shortening will happen. So, tension development only in isometric exercise and muscle shortening in isotonic exercise. What are the various exercises that you can group in these two? All the aerobics, the so-called aerobic exercises, they belong to the first category, isotonic exercises. So running, jogging, cycling, swimming, etc. Because there is muscle shortening in these exercises. There are rhythmic oscillatory muscle contractions. Agonist, antagonist are contracting, and there is muscle shortening in these exercises. They are also called as dynamic exercises. Generally, whole body or major part of the body musculature is involved in these. Isometric exercise, we've said that sustained tension development but no shortening. That is isometric exercise. I mean, if you are pushing against a wall, you can see that muscle tension gets developed, but there is no shortening as such. Or if you pull the pulley down, the weights and the pulleys, if you pull the pulley down and hold it, you can see that there is sustained tension development in the muscle, but there is no shortening as such. Tension development only. And therefore, isometric exercises, which are also called as static exercises, generally they are in a static position. They include the weights and the pulleys. And you will see now that the cardiovascular changes are different in these two types. Let's start with the first one. Isotonic exercises or dynamic exercises. What are the changes? There is increased stroke volume. Yes, heart is contracting stronger. There is increased heart rate. Yes, heart rate also increases. And therefore, the product of these two, that is cardiac output, also increases. This happens because of an increased sympathetic discharge, increased sympathetic activity. So, heart contracts forcefully, heart rate also increases. Now coming to the blood pressure, that's more important. Look at the blood pressure changes in this type of exercise. Blood pressure, let's show it with a graph so that you can have a visual input. Here is the blood pressure plotted against time into exercise. Systolic blood pressure increases. Systolic blood pressure increases because increased sympathetic discharge. So heart is contracting more forcefully. Systolic blood pressure will increase. But diastolic blood pressure either remains the same or slightly decreases. Yes, diastolic blood pressure decreases. And therefore you see from the graph itself, the pulse pressure widens. The pulse pressure has widened. It has increased. You can see the difference between the two pressures. The gap has increased. So let's write it down, increased pulse pressure. Now the question is, and the entire thing should revolve around this. Diastolic blood pressure decreases. Why? Look, the reason is muscle chemoreflex. You know, the exercising muscles, they release certain chemicals, CO2, H+, lactic acid. These chemicals are released. And you know, we have done this in the chapter of blood pressure, that these are the vasodilators. So they cause vasodilation in those exercising muscles. Now you will have to recall that we have also discussed about the peripheral resistance. Which blood pressure is indicative of the peripheral resistance? Diastolic blood pressure. We have done that. And we also said that which vascular bed is the greatest contributor to the peripheral resistance? Skeletal muscle circulation. Remember, we did that in the chapter of blood pressure. So, vasodilation in the muscles would mean that there would be a decrease in peripheral resistance, because more than half the peripheral resistance is contributed by the skeletal muscle blood vessels. Muscles are contractile tissues, tissue, and they keep on contracting, so they compress the vessels. But here what happens is the muscles contract and then relax. There is rhythmic contractions and relaxations of agonist and antagonist in these types of exercises. Please note that point. So when the muscle will relax, the blood vessels will open up. In fact, they will dilate because of these chemicals. So there will be a decrease in peripheral resistance, and therefore there will be a decrease in diastolic blood pressure. Diastolic pressure falls, decreases. That's the reason. And in fact, because of this, these types of exercises are advised in hypertensives, because hypertension is mainly labeled on the basis of diastolic blood pressure, and these exercises decrease the diastolic blood pressure, so they are advised. We will see in some time that the isometric exercises are actually contraindicated in the hypertensive individuals. These exercises are advised, but those are contraindicated. The strength training, weights, pulleys. Right. So these are the cardiovascular changes during isotonic exercise. Now, coming to the isometric exercises, also called static exercises, the weight training, strength training, pulleys. Now, first of all, in these exercises, there is sustained tension development in a group of muscles which are actually performing the exercise. This is largely a theoretical type of discussion. Actually, the changes are little complex, but for the MCQ sake, we are making it as a distinction that in these exercises, there would be a sustained tension development in the muscle. As I gave you the example, you pull the pulley down and hold it. It's a sustained tension development. The muscle is not allowed to relax, at least for some time. Okay. So because of the sustained tension development in those muscle groups, there would be a sustained compression of blood vessels and sustained compression of vessels in the skeletal muscles. Meaning, what will happen? There would be an increased peripheral resistance. Okay, so the cardinal difference between the isometric exercise and the isotonic exercise is that in the isotonic exercise, you are allowing the muscle to relax alternately, and the blood vessels are allowed to open up in those skeletal muscles. Here, that's not happening. And increased peripheral resistance, therefore increased diastolic blood pressure, and hence these are contraindicated in the hypertensive individuals. These exercises are contraindicated. Right. Let's look at our MCQ. The MCQ was asking which of these will not increase in the isometric exercise. So resistance will increase definitely. Systemic vascular resistance and peripheral resistance, it will increase. Okay. Now if the peripheral resistance increases, diastolic blood pressure also increases. What was the formula for mean arterial pressure? Remember, diastolic blood pressure plus 1/3 of pulse pressure. So mean arterial pressure is also quite dependent on the diastolic blood pressure, and therefore if the diastolic pressure increases, there would be an increase in the mean arterial pressure. We are looking at the MCQ and the options given. So these two will certainly increase. Now we are left with heart rate and cardiac output. Well, heart rate increases. Yes. So the answer to that MCQ was cardiac output. Now the question is, how come? Because cardiac output is a product of stroke volume and heart rate. So if the heart rate increases, cardiac output should also increase. No, heart rate increases, but if the stroke volume decreases, then the cardiac output will not increase. And that was the question, or rather answer to that question, cardiac output. Let me just explain this quickly. Heart rate increases because there is a slight increase in sympathetic activity. But stroke volume decreases. Let me tell you the logic behind it and the physiology. First of all, logic. Why the cardiac output will not increase? Look, whenever the cardiac output increases, some tissue is demanding the extra blood flow, and therefore the cardiac output increases, and that extra blood flow is going into that tissue. In this case, muscle is demanding the extra blood flow, but then muscle is compressing its own blood vessel. Its blood vessels within the muscles are getting compressed, as we have said that this is a sustained tension development. And then therefore, even if the cardiac output increases, where will it go? That increased cardiac output, that extra blood flow. It can't go into the muscle which is exercising because the blood vessels are in a sustained compressed way. So even if the cardiac output increases, it cannot go to the muscle. That's the logic behind this. And what is the physiology? See, muscles are compressing the blood vessels within them. So what happens is, the blood coming in will also decrease, and the blood going out will also decrease, and therefore venous return will decrease. And if the venous return to the heart decreases, Frank-Starling law, decreased filling, decrease will be the stroke volume. That's how we can explain this particular MCQ. And these were the changes in isometric exercise. So that was a shortish topic, the exercise and cardiovascular changes. Let's take a small topic, the cardiovascular reflexes. The baroreflex mechanism, I have described it in the section of blood pressure. So you can refer to that and then go through these videos. The important reflexes, let's just summarize those reflexes. Bainbridge reflex. This reflex is related to the heart rate. That there is a sudden increase in the heart rate and therefore the cardiac output because of an increase in venous return. That's the Bainbridge reflex. So if a person is put on IV saline, for instance, or any other reason that increases the venous return to the right side of the heart, there is increased venous return. In this case also, IV saline is given, and therefore there will be a sudden increase in the heart rate and cardiac output. This is said to be the Bainbridge reflex. What's the mechanism? Increased venous return to the right atrium would cause a stretch of the right atrial musculature, and SA node, which is embedded in the right atrial musculature, reflexly it increases its discharge. So that's been called as the Bainbridge reflex. Increased SA nodal discharge and the sudden increase in the heart rate. Now this is happening from a mechanical stimulus, and naturally heart will mainly have the mechanical stimuli because heart is distending, then contracting, so systole, diastole happening alternately. And these are the mechanical stimuli for the receptors in the myocardium. But then even the non-mechanical stimuli, for example chemical stimuli, can result in the reflexes initiated and change in the heart activity. One such reflex is the Basal-Jarisch reflex. What is important about this Basal-Jarisch reflex is that the non-mechanical stimuli also can cause alterations in the heart rate. So this was demonstrated by Basal and Jarisch, and therefore it is named after them. It goes something like this. In an experimental preparation, injection of a chemical veratrum, which is a plant alkaloid, this injection was given, and what was observed was that there was bradycardia, hypotension, and there was also apnea, which is a respiratory change. Bradycardia, hypotension, and apnea. So that's the ventricular chemoreflex or Basal-Jarisch reflex. What happens is there are receptors thought to be in the ventricles and in the coronary arteries, coronary vessels, and they would sense this chemical and they will initiate the reflex. The signals will be sent via the vagus nerve, nucleus of tractus solitarius, and then the efferent fibers will bring about this change, the vagal efferents, hypotension and bradycardia. So that's a Basal-Jarisch reflex. But I told you the difference between the first and the second one is that the first one by the mechanical stimuli, second one non-mechanical stimulus. Then we have the other reflexes, for example vagovagal reflex. You know, it has been observed that there is sudden fainting attack whenever there is let's say sudden painful stimulus to some part of the body or some emotional disturbance. You might have seen this, that sudden painful blow to the body or some emotional some kind of a sad news or something, and the people faint, they collapse. That has been said to be because of the vagovagal attack or vagovagal reflex. So that painful stimulus is said to cause sudden withdrawal of the sympathetic discharge and excessive activity in the vagus. So what happens is withdrawal of the sympathetic tone or sympathetic discharge and increase in the vagal firing would cause the bradycardia and hypotension, sudden fall of blood pressure resulting in decreased cerebral blood flow and the fainting. So such fainting attacks, or commonly called as syncope, they are said to be from the vagovagal reflex or vagovagal attack. Apart from these, as I said, there are baroreflex mechanisms and chemoreflex mechanisms. I have described them in great detail in the section of regulation of blood pressure. So I would suggest you all to just refer to those quickly along with this to have a better understanding of how these reflex mechanisms also are coordinated, how the afferent impulses are sent to the vasomotor center, and what are the components of the vasomotor center. So that was a shortish topic, the reflexes related to the cardiovascular system. We have seen one Starling's law in the skeletal muscle, and we also saw Frank Starling law in CVS. They were related to the skeletal muscle contraction or cardiac output, stroke volume, etc. This is different. It's not related to that Starling. I mean, in the sense that Starling's forces and Starling's equilibrium is a term used in the context of filtration of fluid at the capillaries in the tissues. So what forces are acting in and around the capillaries, and how the fluid moves out of the capillaries into the tissues or back into the capillaries. All that is described as Starling's equilibrium. So there will be formation of interstitial fluid, excess formation of interstitial fluid can be drained away. I mean, that fluid can be drained out by the lymphatic channels, and if it can't be drained out, then it accumulates, resulting in the edema. So all that is a conceptual topic. So let's understand this particular phenomenon. We are talking about the pressures or the forces which are acting in and around the capillaries in the tissues, and how they cause the movement of fluid either out of the capillary or back into the capillary. So basically, at a very basic level, we need to understand two forces. First is the hydrostatic pressure. You know the concept of hydrostatic pressure. We've seen it elsewhere in some other video. Let me just therefore say it once again. At a very basic level, hydrostatic pressure means wherever there is accumulated fluid. Look, hydrostatic. So this itself suggests that stationary fluid. So whenever there is accumulated fluid, it will exert this pressure, hydrostatic pressure. But you need to know two more things about it. One is, more the accumulated fluid, greater will be the hydrostatic pressure. That's quite obvious, because when we talk of hydrostatic pressure in the column of water or column of fluid, you know, at the surface, if it is 1 atmospheric pressure, then as you go deep down into the water or into the fluid, the pressure goes on increasing, and therefore more the fluid accumulated, more will be the hydrostatic pressure exerted. And the most important thing that you must know is that here is a force that pushes the fluid out of the compartment into the neighboring compartment. I repeat once again, hydrostatic pressure is a force that forces the fluid out of that compartment into the neighboring compartment. Let's see this in the context of capillaries in the tissues. We have capillary hydrostatic pressure. This pressure will cause the fluid to go out of the capillaries. Well, before we proceed, let me just add, we will be requiring all this in the discussion of glomerular filtration rate, because there we will be talking about filtration of substances and fluid from the glomerular capillaries. So all these forces need to be understood clearly. Okay, coming back to this, capillary hydrostatic pressure. This is a force that will push the fluid out of the capillaries into the interstitium. Right? We are talking about the capillaries in the tissue. So outside the blood vessels, there is interstitium. On the other hand, there is since interstitium has fluid, accumulated fluid, therefore there will be interstitial fluid hydrostatic pressure. The accumulated fluid, the interstitial fluid, will exert this pressure, interstitial fluid hydrostatic pressure, and this will force the fluid away from it, as I mentioned, means back into the capillaries. That's the first point, or the first force. The second force that we must understand in the Starling's forces, the Starling's equilibrium, is the colloid osmotic pressure or colloid oncotic pressure. Well, these terms are used interchangeably, osmotic, oncotic, but there is a slight difference. Colloid osmotic pressure is exerted by the proteins, first point. Or when do we use the term oncotic? That's the pressure exerted by the macromolecules, so large protein molecules. A slight difference, but we can use these terms interchangeably to understand the concept. Okay, so it's exerted by the proteins. And the second point is this is a force or pressure which pulls the water towards it by osmosis. Pulls the water towards it by osmosis means it will pull the water into that compartment wherever these proteins are present. So we will have plasma colloid oncotic pressure, and this force will pull the water back into the capillaries, right? There are plasma proteins, they will exert this pressure and it will pull the water back into the capillaries. Whereas in the interstitium, some proteins have been leaked out, some proteins have been filtered out, they have come out of the capillaries, they have come into the interstitium, and therefore we will also have interstitial fluid colloid oncotic pressure because of those proteins which have come out of the capillaries into the interstitium. And this pressure, this force will pull the fluid out of the capillaries towards it, means out of the capillaries. So far we have seen 4 forces which are acting in and around the capillaries. Basically we saw 2 forces, hydrostatic pressure and colloid oncotic pressure, and then these 2 forces are present inside the capillaries and into the interstitium. So in all we have 4 forces which are acting. 2 of them are causing the movement of fluid out of the capillary. 2 pressures, capillary hydrostatic pressure and interstitial fluid colloid oncotic pressure. These 2, if you add them together, this is a net pressure that is causing the fluid to come out of the capillaries. Fluid will be filtered out of the capillaries. And then we have 2 forces or pressures which cause the fluid to go back into the capillaries. Fluid will be absorbed back into the capillaries. What are those 2 forces? Plasma colloid oncotic pressure, which pulls the water back into the capillaries, and interstitial fluid hydrostatic pressure. This also forces the fluid to go back into the capillaries. So addition of these two forces, we have a force that will push the fluid back into the capillaries. So once you understand this, then it becomes easier to understand the edema, for instance. Look, edema is excess accumulation of fluid in the interstitium. What all pressures can lead to edema? For example, if there is increased capillary hydrostatic pressure, this can happen in the vessels of the lower limbs in the conditions of congestive cardiac failure. If the heart is failing, then the blood gets pooled in the lower extremities. And as we've already mentioned, more the fluid accumulated, more will be the hydrostatic pressure. So hydrostatic pressure in the vessels of the lower limb will increase capillary hydrostatic pressure. So it will push more and more fluid out of the capillaries, and therefore it will result in the edema in the lower limbs. So that's one reason of edema formation. Second, see, plasma colloid oncotic pressure. Now, if this is a pressure that is pulling the water and fluid back into the capillaries, what if this pressure decreases? What will happen? The fluid that is supposed to go back into the capillaries in that amount, it will not go back. Means from interstitium, the fluid will not go back into the capillaries in that much amount. So fluid will accumulate in the interstitium. When there will be decrease in the plasma colloid oncotic pressure. Why would that happen? We said just now that it's the proteins, plasma proteins, which exert the plasma colloid oncotic pressure. So if there is a decrease in the plasma protein concentration, then there will be a decrease in the plasma colloid oncotic pressure. So the question is, when is it that the plasma proteins decrease? Their concentration decreases. In which conditions? Primarily two conditions which cause this: hepatic conditions and renal conditions. Liver diseases. Look, liver synthesizes the plasma proteins. So if there is a severe hepatocellular disease, then plasma protein synthesis itself will be affected. Or the conditions of kidney, in which the proteins are filtered out and lost into the urine, nephrotic syndrome, for example. In such conditions, the plasma protein concentration will decrease, and therefore plasma colloid oncotic pressure will also decrease. It was expected to pull the fluid from the interstitium back into the capillaries. That will not happen, and fluid will accumulate in the interstitium, resulting in the edema. So these are the two main reasons or physiologic factors that can cause edema. Let's move on. There are some more reasons for edema. We will see that in a moment. But let's just move further. And let's talk about this, the Starling's equilibrium. Look, for a capillary, there is an arterial end from where the blood is entering the capillary, and there is a venous end of the capillary where capillary blood leaves and goes into the venous compartment. So the point is, all these four forces which we discussed just now, they are all acting on the entire region. Means they are acting on the arterial end of the capillary as well as venous end of the capillary, but they are not same everywhere. These pressures are not same for the entire region or entire length of the capillary. I'll give you an example. Look, capillary pressure at the start of the capillary is about 30 mm of Hg. It will differ from tissue to tissue, but this I am giving you the average figure, 30 mm of Hg. And the plasma colloid oncotic pressure is about 25 to 28 mm of Hg. Right. So you can see that there is a net difference, and the pressure that is driving the fluid out is greater. But then if you come on the venous, at the venous end of the capillary, where the capillary ends and veins start, venules and vein, the pressure in the capillary is only about 10 mm of Hg. Right? 30 at the start and 10 at the end. So here the capillary hydrostatic pressure is much less compared to the plasma colloid oncotic pressure. The point that I am trying to make is at the arterial end of the capillary. Now listen to this part very, very carefully. At the arterial end of the capillary, the net of all these four forces, we have seen the four forces, the net of these forces favors the fluid to go out of the capillaries. At the arterial end of the capillary, let me quickly recap once again. Two forces cause the fluid to go out and two forces cause the fluid to go back into the capillaries. So there will be a net, and the net of these four forces at the arterial end, it is in the favor of fluid to go out. Those forces are stronger or greater. So fluid goes out of the capillaries on the arterial end. On the venous end of the capillary, if you see the net of these four pressures, the net is in the favor of fluid going back into the capillaries. I mean, I told you just now, the capillary hydrostatic pressure is much less on the venous end of the capillary. That pressure was going to drive the fluid out, but it's very less. So if you calculate the net of all these four forces are in the favor of fluid going back into the capillaries. Okay, and therefore let's just write it down here. Venous end, arterial end, the fluid leaves the capillaries, and on the venous end of the capillaries, fluid is absorbed or fluid goes back into the capillaries. Okay, so that should be understood, that fluid is moving like this. Here is a capillary in the tissue, arterial end, the fluid goes out, and on the venous end, the fluid goes back into the capillaries. But now another very important aspect, the net force which is causing the fluid to go out of the capillary on the arterial end, and the net force net of all those four forces, okay, which is causing the fluid to go back into the capillaries. These two net pressures are also not equal. What I'm trying to say is, all the fluid that goes out of the capillaries into the interstitium, all that amount of fluid does not come back on the venous end of the capillary. Why? Because, as I mentioned, the net pressure at the arterial end and the net pressure on the venous end, they are not equal. The net pressure of all those four pressures that we discussed, on the arterial end, it is slightly greater, roughly in the range of 0.3 mm of Hg or slightly more than that, but it is slightly greater than the net force on the venous end. Which means what? Which means all the fluid that comes out of the capillaries on the arterial end does not go back on the venous end of the capillary. All the fluid does not go back. Why? Because net pressures are not same on the two ends. So some fluid will remain in the interstitium because of this net balance of forces, which we calling as Starling's equilibrium or Starling's forces. Some amount of fluid will stay in the interstitium and it will become the part of interstitial fluid. So that is how interstitial fluid is formed. And we have already seen this. If the pressure increases, capillary hydrostatic pressure increases, or plasma colloid oncotic pressure decreases, then there will be more and more fluid coming into the interstitium, and excess interstitial fluid accumulation is edema. So interstitial fluid is formed in this manner. But to prevent the edema formation, we have an additional channel which is called as lymphatic circulation. An additional channel or additional circulation which is called as lymphatics. So what happens is, say for instance, because of increased capillary hydrostatic pressure, more fluid is leaking out into the interstitium. What will happen? That excess fluid will enter the lymphatics in that tissue. And therefore you must have noted that lymphatics have the similar composition similar to that of interstitial fluid. It's the interstitial fluid which is being circulated. So that excess interstitial fluid will enter the lymphatics. Then the lymphatics from all over will join the major duct, the thoracic duct, which will run up to the thorax, and then that thoracic duct, the major lymphatic vessel, will finally open at the junction of two great veins, the subclavian vein and internodular vein. So lymphatic will finally drain in at the junction of these two vessels, or these two veins rather. So the point is, first point, excess interstitial fluid is drained away out of the tissue by the lymphatics. And therefore third reason for edema formation is if the lymphatics are blocked, if the lymphatic vessels are blocked, then the excess interstitial fluid cannot be drained out, and that also can result in edema. One classic example of this type of edema, in fact it is called as lymphedema. It's seen in elephantiasis. In elephantiasis, which is happening from the parasitic infestation, it blocks the lymphatic vessels. of the lower limb, and therefore filariasis, of course, the microfilariae, it blocks the lymphatic vessels of the lower limb, and the lower limb or leg becomes much wide in diameter because of that accumulation of fluid. So that's the third reason for edema. We have seen three reasons so far. If there is increased capillary hydrostatic pressure, more fluid will leak out. If there is decrease in the plasma colloid oncotic pressure, as in the liver or kidney diseases, then fluid cannot be taken back into the venous system and on the venous end of the capillary, and that results in edema. And this is the third reason. Okay, so lymphatics, basically they perform this major function, and therefore let's also talk about the lymph and its functions. Lymph basically circulates in these lymphatic vessels, and it has a composition which is similar to the interstitial fluid, naturally, because it is circulating the interstitial fluid. Then second point, normally how much is the protein content of the lymph? Well, protein content is there. It's about 2 to 3 gram%. Some of the proteins, they have leaked out of the capillaries and they have come into the interstitium. So 2 to 3 gram%. Only at two places the protein concentration in the lymph is slightly higher, and that is liver and the GIT. The lymphatics draining from the liver, they have proteins up to 5 gram%. That's because the proteins are synthesized in the liver, so there is a greater amount of proteins present there. And even intestines, because proteins and their digestion products are absorbed from the intestines. So higher protein concentration at these two places. But otherwise, this is the protein concentration, and otherwise it's a quite similar in composition compared to the, similar to the interstitial fluid. Okay, next point. What are the functions of the lymph and the lymphatics? Before I tell you the functions, also try to understand. There have been questions, for example, which of the following will increase the rate of lymph flow? Rate of lymph flow through the lymphatic vessels will increase or decrease in which of the following? That is the question which is commonly asked in the FMGE exams. So now it's quite obvious, we can answer that question very easily. Once we know that the factors that increase the formation of interstitial fluid, they will also increase the lymphatic flow. Okay, so for example, increased capillary hydrostatic pressure, it will form more interstitial fluid. Then more interstitial fluid will enter the lymphatics, lymph flow, which is normally about 2 to 3 liters per hour for the entire body, I'm saying. So that flow can increase or decrease in the plasma colloid oncotic pressure, as we have mentioned. Then that also will increase the lymphatic flow because lymph formation itself increases. Right. Apart from these factors, of course, there are some mechanical factors also. You must understand. Mechanical factors can increase the rate of lymph flow. For instance, pressure on the area. For example, take the foot pad. If the pressure is increased over there for some time, the lymphatic flow will increase. Or if there is a pulsatile vessel in that region, even that can increase the lymphatic flow. Look, the blood vessel and the lymphatic channel are close by. So if there is a strongly pulsatile vessel, it can have that compressing effect on the lymphatics, and more lymph will be squeezed and flow will increase. So these are the mechanical factors apart from the Starling's forces that can change the lymphatic flow. Okay, let's see the functions of the lymph. First thing, lymphatics, they return the substances and molecules into the venous blood, into the venous system. But which substances are we talking about? The substances which are large and which have leaked out, but they cannot be absorbed directly on the venous end of the capillary. Such substances can be returned into the circulation via lymphatics. Okay, please try to understand one thing. The lymphatic channels, they are lined by cells in such a manner, lining of the lymphatics is such that it acts like a flap or a valve. Means the substances can enter the lymphatic channel and then that pressure causes the flap to close. So those substances cannot come out of the lymphatics. Well, the point is the lymphatics return the large molecules or the substances which are large in molecular weight. They have come out of the capillaries on the arterial end but could not go back, could not be absorbed back on the venous end. Such substances will go into the lymphatics, and finally, as we have seen, that entire body's lymph drains in the veins. So finally those substances will be drained into the venous system. That's the major function of the lymphatic vessels. Another important function that you should know is absorption of the fats and fat soluble vitamins from the digestive tract. Look, all the nutrients, other nutrients are water soluble, the proteins, carbohydrates. So the nutrients are absorbed into the portal circulation directly from the digestive tract. But even in the case of fats, the short chain and intermediate chain fatty acids, they can be absorbed into the portal blood. But long chain fatty acids, so when I say fats, I mean long chain fatty acids and the fat soluble vitamins, they are water insoluble. So they cannot be absorbed directly into the portal venous blood, portal circulation. Such substances are absorbed into the lymphatics of the intestine. Fats, for example, they are absorbed into the lymphatics in the form of chylomicrons. And because of these chylomicrons, there is a milky appearance to that lymph, for which reason the lymphatics of the intestine are also called as lacteals, because of that milky appearance given by the chylomicrons. Well, the point is that fats and fat soluble vitamins do not get absorbed directly into the portal blood as they are not water soluble. These are absorbed into the lymphatics of the intestine and then finally will enter the venous system. So these are some of the important function of the lymphatics. They circulate the lymphocytes. You know, that's another function. The lymphocytes are to be stationed at the lymph nodes. These are located at some important nodal points. Peyer's patches, for example, are the lymphatics in associated lymph nodes associated with the GIT. So circulation of these cells also is another function of the lymphatic. These are some of the important functions of the lymph and the lymphatic vessels. So that in a nutshell was the Starling's equilibrium, Starling's forces, excess accumulation of interstitial fluid in the form of edema, and what factors are responsible, and then lymph and its functions. That was the summary of these forces. You will have to correlate this when we discuss these forces again in the GFR. We will discuss this in the kidney. So you can revise this again and then go to the section of kidney.